Hi everyone, this is Neel Raithatha, consultant audiologist and director of Wax. Thank you for joining me in my latest video using the Waxxo. So we have a really complex case here. It's of a patient who attended with a really narrow ear, and I actually examined this patient's ear using the endoscope initially, and given how narrow it was, I thought this would be a great challenge for the Waxxo. Therefore, upon examining the ear, I put some drops in immediately because they've had this really hard keratin at the entrance. Or this is probably about a third of the way in actually, and that's why it's really reflective. When you've got skin keratin, it reflects the light back from the light source. Now, I could have reduced the brightness temporarily, but it wasn't really affecting me, so I just continued because I knew once I removed this keratin that I would need to re-increase the brightness. Now, you may have noticed you can see a lot of the specular, and that's because this ear is so narrow that I used our pediatric size specular. This is a really narrow specular. It's 3.5 millimeters in diameter. Now, the suction probe itself on screen is 2.1 millimeters in diameter. And this is where I feel the Waxxcope's really great, because we have this slot at the top. You probably see it from around 11 o'clock to about 2 o'clock. And that's where you insert the instrument through. If the instrument went through the middle of the speculus, so imagine there's no slot and it's completely closed, so there's no opening. The specular is going to take up almost more than half the view of what you can see, which can make it very difficult to perform procedures in narrow ears. But with the slot, because the instrument is coming from a higher angle and it's not obstructing the camera, because again, the camera is going right through the middle of the specular. And so if I was to insert the instrument, the suction probe, through the middle of the specular, not only would the physical size of the instrument obscure the view, but the camera lens itself will be obscured by the instrument. Now, I've just managed to remove that outer layer of skin, and the next layer is quite crusted and hard. So I'm having to leverage it with the suction probe. Now, I know visually a lot of people may not like the view, especially when you compare it to the endoscope, but this is actually a view that most people see when they perform earwax removal. If you're using a microscope, for example, even with head loops, because you've got a specular, your view's more narrowed. Yes, if anyone who doesn't enjoy the view, I understand that, but this is for procedurally, the Waxxcope, this is why it's so useful, because it helps to straighten and widen the ear canal. If using the endoscope, a specialist would need to dilate the ear open, because the entrance is almost completely shut. They'll have to open it up using the endoscope and simultaneously maneuver the wax with their instrument. So a lot of people can find that difficult. So what I'm trying to do is just separate some of this skin, and this is mainly skin. I wouldn't call it earwax. It's not keratosis obturans. The patient didn't attend with any pain. There's no widening of the ear canal. They have got a natural widening of the ear canal as we go deeper, but it's not a remodeling of the bony part. Now, this potentially may have developed into a keratosis obturans if not removed. This patient's 94 years of age. They last attended 4 years ago. And I remember struggling back then as well with this particular patient. I was reading my notes. So I have recommended that if possible they can attend more frequently, because it was really blocked. But the patient was really still, and it did make a big difference at the end of the procedure. You could hear so much better. So I'm just trying to leverage it from the top and bring it forwards. So there's a little plug of keratin here that's going to come out in a moment. I'm just going to tease that away. Again, I'm just going to stretch the ear open. So the side walls of the specular is what it's doing. It's pushing the cartilage on either side of the ear canal away to stretch open the ear, so I've got access. So you see a bit of oil collected at the bottom there, so that's going to come away as we vacuum. And I'm using this dragging movement, so I'm going to the top and dragging it down and coming out at the same time. So we're making good progress. And the key when you insert the specular is, this is the patient's right ear, so the second bend is on the right-hand side. And I'll kind of show you that next time I enter. We want the right-hand side of the specular to kind of tuck inside the second bend. And once you've done that, You can really straighten and dilate the ear canal. The reason I'm being a bit technical in the procedure, it's just because obviously we're training a lot of people, and I know a lot of people that I've trained enjoy watching the videos. So I'm just trying to make it a bit more educational for them as well, so they can see some of the tips and tricks. So this is quite hardened skin. So this is more stuck at the bottom, so I'm trying to wriggling it and coming up. Sometimes when you've got wax stuck at the bottom of the ear canal, it may be trapped in the inferior recess, which is a little basin just in front of the eardrum. So you have to lift it up and away. And I'm just going back to the top to separate this bit. And with skin, it's quite stretchy. So as you're extracting it from the ear, sometimes it pulls and stretches, and you get ribbons of skin kind of coming away. Now you can see at the bottom, that's the floor of the ear canal. It's probably halfway in the ear, and then there's a little trench here, so it widens beyond this point. So I'm having to lift the wax up and over to remove it. So you can see I'm going to the bottom and going up. I'm trying to wriggle it through. This is where the wider part of the ear canal meets the narrow part. So this is the most trickiest part of the procedure, because the plug is bigger than that part of the ear canal. So I'm just trying to go in a bit further with the speculum, just to see if I can stretch it a bit wider at the entrance. I've just adjusted the focus. And again, I'm lifting up and over. I'm almost there. And that nice big plug came away. So this is almost entering the speculum now, so I'm going to come away with the speculum as I'm extracting it. And the eardrum is now partially visible posteriorly. So this is more on the front part of the ear canal, so I'm just angling the speculum in that direction. I'm going to lift this away from the canal wall. And this last bit was quite tricky. It was stuck to the top part of the ear canal and posteriorly. So the second bend is just there to the right as I entered. So I wasn't able to use the bigger size speculum. It just wouldn't fit into this patient's ear. And the bigger size one is probably normally the smallest size. So when you perform earwax removal, you get different size specula. And the most common size is a 5mm one, which is our size 3. And the next one is, the smallest one typically is around 4mm, which is our standard size. So for most ears, you can use our 4.25, but we've also developed this extra small specula, which really helps to get into the narrow, bendy, collapsed ear canals, or pediatric ears that's a lot smaller. So this last bit is just adhered to the back part, and it's tricky to move. As I'm suctioning, it's almost like pushing it in. So in a minute, I think I'm going to angle to the back and to the roof and peel this bit. You can see there's skin adhesion. And again, I'm trying to tuck it in. The canal widens at this point, so I want to bring it in through the narrowing. And you may have noticed the patient, it's got quite hairy ears, so as we get older, for men in particular, the ears get a bit hairier. So I'm going to stretch the ear open again. I'm going to look at the roof of the ear canal. I'm going to try to get a good suction grip, and I've released that plug, and I'm going to slowly bringing it away. So you can see the outer coating, the skin ribbons that's enveloped this plug. It's just got trapped, but we managed to bring it out. Now we're going to have a good look at the eardrum. You can see beyond that narrowing, the ear canal does widen. I'm going to get the eardrum into focus. That's the hammer bone. You can see the umbo, the light reflex. See all the capillaries supplying the hammer bone. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.